Well, thank you, Holly, and good morning. About 15 years ago, I was in the Oregon Health Sciences building, and I saw a sign that said quality, service, cost, and below it in bold letters it said pick any two. That was the mindset of the 20th century. In the 21st century, we can do better. Medical knowledge has progressed, information technology has leaped forward, and we have the opportunity today to provide superior quality, convenient service at a much, much lower cost. I will be speaking this morning about information technology and the role that it can play, but I believe that it can take $1 trillion out of American healthcare over the next decade. And the examples I'm going to use are not theoretical, they're ones that we are doing today inside Kaiser Permanente. I read an article by the Rand Corporation that talked about how long it takes for a major advance in medicine to become common practice. And it said that it takes 17 years, which means that the average physician in this country is living in 1994. Whether you want to look at the iPhone and the iPad, whether you want to look at Google or Facebook, simply go to the physician's office, and what you'll see is an absence of technology that patients expect from banks, from finance, from airlines, from retail. And the question we have to ask ourselves is, why do we believe in medicine that we can offer people so much less than today they have in every other aspect of their life? I have a chance to teach at the Stanford Business School. I teach courses on strategy. And in that process, we get a chance to look at hundreds of case studies. And American healthcare stands out as an exception. American healthcare most closely resembles the 19th century cottage industry. It is fragmented, individual physicians working alone or in small groups, unconnected with others. It is fee-for-service, piecemeal, rewarding volume, not outcomes and quality. Besides billing and claims, there's very little that's not paper-based, and there's simply no leadership structure. As I try to look at companies and organizations that have been successful across time, I can't find one in hundreds of case studies in dozens of industries that has had a lack of integration where R&D and sales and marketing, finance don't work together as one. I can't think of another business where the suppliers determine the volume of services provided and can generate the cost to the organization. Every single successful company in this country has used information technology in very, very powerful ways. And I don't mean just an EMR. I'm talking about the internet. I'm talking about video. And I can't think of an organization that doesn't have a leadership structure capable of implementing change, capable of being able to make difficult decisions and to allocate capital simply outside of American health care today. As Bruce Badakian pointed out, we do have a health care crisis, but actually the one area I might disagree with Bruce about is I think that the window that we have for change is far smaller than even he implied. When I look at Greece, Italy, Spain, Portugal, Ireland, Iceland, when I travel to Washington, D.C., when I talk to governors, it's very clear that very soon someone, maybe it'll be China requiring that its debt be repaid, maybe it'll be the S&P downgrading American bonds to the point that the interest rates go up. At some point, American healthcare in the very near future will have to be able to address the affordability challenges that Bruce pointed out so well. And at that point, if we have not used information technology to change healthcare delivery, we'll have no choice but to move to a two-tier system of medicine. And not the two-tier system of medicine today. Today we have a system where the poor often don't have the same level of healthcare provision that the rest of the nation does. I'm talking about a system where the middle class simply is given less and less. Higher deductibles they can't afford, less and less coverage, until actually there's rationing as the solution to the American healthcare crisis. And once that happens, we'll never go back. We'll never have the opportunity that we have today. Today is the last great hope, I believe, for American medicine. I do understand how tough it is to change the structure of medicine. I do understand how tough it is to integrate. I understand how tough it is to change the financing, to be able to move from a fee-for-service to a prepaid or bundled way. I do understand difficulty even with technology. And I do understand how tough it is to create physician leaders when simply there are none today. But I don't believe that we have a choice. If we want to save American medicine, we have to extract that $1 trillion out. So I thought this morning I'd spend some time going through some of the opportunities that exist. And again, in the end, asking, why do we believe that we can provide so much less to patients than they have in the rest of their life? So let me start by getting on an airplane with you. We fly to South America. We arrive at the airport. We realize that we don't have any local currency. We need to take a cab to the hotel. We reach into our wallet to get an ATM card. There's a machine there run by a local bank. The bank doesn't even have branches outside of the city in which we're landing. And yet that machine, the ATM machine, knows exactly how much money we have in our bank account in the United States. And is so confident that it knows what we have that it gives us money in local currency. And now we look across America. It's Saturday night, and a patient comes to the emergency department with chest pain. The most important piece of information, the EKG done in the doctor's office 2 days later, will not be available until Monday morning, 36 hours after it can have the most important positive impact on quality. 36 hours after it can actually lower, not improve quality, but lower the costs. Why do we provide so much less to our patients than banks do? We spend, again, a lot of time talking about the opportunities that exist using the electronic medical record, but I want to focus on three. I want to talk about the impact of well-done prevention. I want to talk about sepsis, and I'd like to talk about hospital readmission, and how the availability of information can take tens of billions of dollars out of American healthcare every single year in simply these three areas. Some of you may have seen the NCQA, the National Committee for Quality Assurance, data on quality. It's the Foundation for Consumer Reports, and in that report, Kaiser Permanente is ranked #1 in the nation for patients over the age of 65. And we have a division of research. It's the largest division of research anywhere outside of a university or government center. And I asked them the following question. If every American, every insured American, because those are the ones on that report, receive the same level of preventive services as we provide in Kaiser Permanente based on that report, what would be the impact on the health of America? And they said, based upon this information, if every American received the same care that we're providing today, there'd be 200,000 fewer heart attacks and strokes a year. 200,000 heart attacks and strokes. That's about $5 to $10 billion. And no one wants to get a heart attack and have it treated. You'd like to avoid it. That's better quality, better service, $5 to $10 billion lower cost. 75,000 people would not die from cancer after having chemotherapy, futile chemotherapy across time. Billions and billions of dollars, higher quality and lower cost prevention. You know, it's strange. If you walk into an orthopedic surgeon's office and have surgery, and you go to the operating room and have a complication, we consider that a major medical error. But if you go to that same orthopedic surgeon's office and haven't had a mammogram and you die of breast cancer, we somehow don't see that as a quality failure. Same woman's dead. Same child doesn't have a mother. Same husband doesn't have a spouse. Same parent doesn't have a child. And somehow we don't understand that prevention is quality and that prevention lowers cost when it's done at every single point of contact, and that's what the electronic medical record can do. If at every point of contact we're able to do the prevention that's possible, we can take tens of billions of dollars out of the healthcare system. Sepsis is another great example. I know some of you are not clinicians. Sepsis is a systemic infection. It actually comes almost in two varieties. About half of the people sepsis, first of all, is the most common cause of death of hospitalized patients. It accounts for 2% of admissions and 1 out of every 6 deaths. And it really comes in two varieties. One variety is the patient who is old. They often have a lot of associated disease. When they show up in the emergency room, they have septic shock. They're very, very sick. Everyone recognizes that they're put in the hospital, and Sometimes they get better and sometimes they don't. But about half of the time, the patient showing up is not that old, very sick person. It's actually a moderately young person, a person maybe with an infected kidney stone. And the emergency room physicians and the admitting physicians simply don't recognize, because the person often is relatively young and not that unhealthy, that they have a life-threatening condition. And what they do is they admit the patient to the hospital for IVs, a small amount of IVs and antibiotics, and then a couple of days later, the patient develops the septic shock. And now they're in the ICU for weeks at a time. Now they have a prolonged hospital stay, as I say, a very high mortality. But we could have recognized that. The data says we could have recognized that back in the emergency department. And information technology systems allow algorithms to make sure that the physicians in the emergency department order the laboratory test that's necessary, called a blood lactate. And they can make sure that based upon the results of the blood lactate, they can have algorithms in place to make sure that we provide aggressive treatment, not 3 days later, but at the particular time. And instead of spending weeks in the hospital, they can spend a matter of a couple of days and go home healthy again. The opportunity to use advanced information technology systems to make sure we provide premium care in sepsis, early identification and treatment, lowers the mortality by 30%, lowers the cost across this nation by tens of billions of dollars. A third example to me is in terms of hospital readmission. There are 3 reasons why people come back into the hospital. One reason is the disease just gets worse. And there's some people trying using home monitoring to be able to improve that. It hasn't yet been demonstrated that it's particularly efficacious, but it might be over the course of time. But there are 2 other reasons why people get readmitted that advanced information technology systems can address. The first one, pointed out in the New England Journal of Medicine, is that half of the time in America today, when patients go home and get readmitted, they've seen 0 physicians, no physician between discharge and being readmitted. Now think back, the day before they were in the hospital, they were seeing people constantly 24/7. And now they're getting no care for 3 or 4 days. What would have happened if the day before, while they were in the hospital, they got no care? That's what happens in American medicine today. That handoff is a chasm. People just drop down through it. Electronic medical record can connect the outpatient, the inpatient physicians, can make sure the information is available, can make sure that the linkage happens, to make sure that the physician receiving the patient the day after discharge continues the care. And the third area has to do with medication. Patients come in the hospital today on 8 medications. They go home on 9 medications. But 3 of them are different and 2 of the doses are different. We had RNs figuring out the medication the day before, and now we're expecting an elderly patient who's been in a hospital, who may be mildly debilitated, to figure out the medication. We can use iPhones and iPads to be able to educate people, to tell them what to take the medicine, to make sure they don't take double the dose or half the dose. They don't confuse the medication before admission with the one after admission. We've lowered the readmission rate by 43%. Tens of billions of dollars information technology can do if we change the structure, if we change the financing, if we provide the leadership. But it's not just the electronic medical record. I think we have to understand the power of the internet. I don't know how many of you came here by airplane, but if you came here by airplane, how many of you went to the travel agent to pick up your paper ticket? Yeah, I don't think very many hands. No hands went up in the room for those of you on the webcast. And yet, if you have a child going to kindergarten in a couple of days, what do we know? You've got to miss work. You go to the pediatrician's office to pick up the printed form because you have no ability to use the internet to get that information and be able to have it so that your child can begin school. I have a daughter who's in her 20s. She works at a startup in Silicon Valley where I live. If you work at a startup in Silicon Valley, you work 16 hours a day, 7 days a week. And one day she asked me about a problem she had with a thumbnail that was getting progressively worse. When you're the father of a daughter and you see a thumbnail problem, you assume one of 2 things. Either number 1, she has a life-threatening fungal infection, or it's cancer. It's one or the other, if you're a father. And so every day you talk to your daughter, you text your daughter, because actually you don't talk to her because you text your daughter because she doesn't talk on the phone, but you text your daughter, have you seen the physician, have you seen the physician, have you seen the physician? And of course she keeps saying, I'm too busy, I'll do it tomorrow, I'll keep busy, I'll do it tomorrow. And then one day she told me she'd got the problem solved. I said, oh, that's great. How'd you get the problem solved? Who'd you see? She said, I didn't see anyone. I took a digital picture on my camera, I attached it to a secure email, sent it to the dermatologist I had seen 3 years before, and by the time I got to work, there was the diagnosis with the message that the medication was sitting in the pharmacy. Think about the cost and the inconvenience of doing that in the system today. You see a primary care physician, you got to get a referral, you got to get authorization from an insurance company, you got to see the dermatologist. Technology allows better quality, more conveniently, at a dramatically lower price. I often think of a letter I received from a patient who was in Indonesia on an island, a 2-hour boat ride from the nearest medical facility, who developed what she worried might be a significant problem. She sent a secure email to her physician in California, 10,000 miles away, figured out that it was a medication reaction, had medication dose altered, and no significant medical problem. The internet allows us to provide care anywhere, anytime, at a remarkably low cost. In Northern California, we take care of 2 out of every 5 people, about a 40% market share. And those 3.4 million people send between 5 and 6 secure emails to physicians every year. If you think about it, if even 1 in 5 of those would have led to an office visit, 1 million office visits a year, that's 4,000 work years, about $280 million projected across this country. The use of secure email could lower the cost, or at least the work productivity reductions, by 28, or increase productivity by $28 billion every single year. And more importantly than that, it's often a matter of a couple of minutes to respond instead of an office visit. Better quality, more convenient, at lower cost. A third area that information technology raises quality and lowers cost is around safety. Imagine now that you are at that airport, and all of a sudden you hear the pilot's voice come on over the loudspeaker. I have bad news and good news. The bad news is that the autopilot's not working. The good news is I'll fly you anyway. And the risk of crashing, instead of being 1 in 100,000, is now only 1 in 10,000, whereas now 1 in 10,000. Would you get on that plane? Some of you might, some of you might not. But if you come into a hospital today that doesn't have barcoding, doesn't have electronic order entry, your chance of a major medical problem is far greater than 1 in 10,000. If you take the IHI numbers, we should have had last year between 500 and 1,000 major medication problems. Using the electronic medical record, we had 0. Not a single major medication problem, better quality, at dramatically lower cost. And another area that I actually believe, if we can reform American medicine, if we can change the structure, if we can change the financing and the leadership, is going to be video. I think video will actually be a major part of how healthcare is delivered in the future, if we're successful, if we can avoid devolving into a 2-tier system. I don't know how many of you have children in college in another part of the, or friends in Europe, but if you do, I'll almost guarantee you use Skype. And Skype is a form of video that's pretty good. But sometimes the images are not clear, and sometimes the audio and the video don't correlate. But Skype is free. If you actually decide you want to purchase a little bit of video, it's actually moderately or very, very inexpensive, very, very low cost compared to forcing patients to come in to get their care. And now the quality becomes exceedingly good. Now the video and the voice is completely linked together. And you start to ask yourself, how do we provide care using video, as opposed to forcing people to come into doctors' offices to obtain the care? So you look at children, not children, but people in their 18, 19s with severe acne who are on Accutane. They go off to college. They need to be checked every month to make sure the acne is responding and to make sure they're not developing psychological problems, because depression is one of the side effects of the medication. And you can arrange a video conference, as we do now, a couple of minutes to make the medical assessment, avoiding the need to fly back, avoiding the need to see a physician. Lower cost, higher quality, Far, far more convenient. We use teledermatology. If you're seeing a primary care physician, 70% of the patients who have a rash, rather than getting referred to dermatology, can have it solved in the primary care physician's office with a combination of video and digital photographs. In the community around us, seeing a dermatologist takes between 3 weeks and 3 months. 70% of patients are getting care within 30 minutes. An immediate diagnosis, immediate treatment, better quality, lower cost. If you come into the emergency room and you're having symptoms consistent with a stroke, the emergency room physician links in with the neurologist at home in a matter of minutes, because providing thrombolytic therapy, avoiding the stroke itself, becomes an opportunity to raise quality and avoid the stroke and the costs associated with providing the care. And the opportunity to use video in place of just a telephone call becomes a 30% better, and the opportunity to intervene immediately allows the strokes to be avoided with a significantly higher percentage. And think about all the follow-up visits we do, whether it's following surgery or patients with chronic disease, the opportunity to use video. But it won't happen. It won't happen unless we're able to change the structure, to change the financing, and to be able to put in place a leadership structure that will make it happen. Clay Christensen from the Harvard Business School talks about disruptive technology. Disruptive technology, as Clay describes it, is a new technological approach that's very clunky. It's not particularly good. The only people who want to use it are those who can't afford anything else, or those who are too young to afford almost anything. That's not what we're talking about. We're talking about technology that everyone in this audience, everyone on the webcast, everyone in America wants for their care. They don't want to get a heart attack or stroke. They don't want to die from sepsis. They don't want to be readmitted to a hospital. They don't want to have to drive to the physician's office to get care when it can be done utilizing a secure message, whether it can be done using video. This is high-end disruption. This is exceedingly different. This becomes the alternative to this nation devolving into a two-tier system of medicine. This is the opportunity to provide in the 21st century better quality in ways that are more convenient, and at the same time take $1 trillion out of American healthcare costs. But it won't happen on its own. It will only happen if we make the decision to do so. So I'd like to close my comments, and before I take a couple of questions, with a little story about a patient. And there's a patient taken care of by a friend of mine in Northern California who was born with deformities of all 4 extremities. He had no foot on one side at birth, a club foot on the other side. He was missing a hand on one side and only had 2 fingers on the other side. And at birth, he had the club foot repaired and a prosthesis put in place. And when he got to high school, he decided he wanted to play tennis. And he figured out how he could take a racket and strap it to the side that didn't have the hand and throw the tennis ball up with the 2 fingers. And he became a pretty good high school tennis player. And then he decided he wanted to go to college and he wanted to play Division I tennis. You can imagine what the tennis coaches said when they got the application from someone born with congenital deformities of all 4 extremities. Every school he applied to rejected him. And he actually went to Loma Linda down here, and other people here from Loma Linda, and walked onto the tennis team and made the tennis team. And he actually won more matches than he lost in college. He's the only athlete born with deformities of all 4 extremities to play Division I sports. And when he finished college, he decided that he wanted to be a tennis pro. And my friend taking care of him asked him, he said, just tell me, how did you have the audacity? How did you have the audacity to think that you could play high school tennis, no less college tennis, no less become a tennis pro? And he said to my friend, he said, choice is more powerful than circumstance. Choice is more powerful than circumstance, and that is what we have today. We have a choice for American medicine. We can let it continue to move forward at the slow pace that it is. We continue to let it remain a 19th century cottage industry. We can simply let it be fragmented and fee-for-service, slowly implementing technology, but not rapidly enough without a leadership structure. Or we can make a decision that that's simply not good enough, that we must offer to the people to whom we are responsible, our patients, the same convenience, the same level of quality, the same level of ease that they demand in the rest of their life. And I believe if we do so, that we can solve America's healthcare crisis. And I believe that generations will look back and believe that this was the right time. And if we don't do it now, the opportunity will pass and we'll never have the chance. Again, in advance, I want to thank you for the leadership you'll provide at making the right choice, because choice is more powerful than circumstance. Thank you very much.